Want to introduce real quick the legislators and others that we have present this morning. First, I want to introduce Becky Lockhart, Speaker. Becky Lockhart is here. So Becky, thanks for being here. We also have Representative Mike McKell. Mike, where'd you go? You're back getting food? Okay. Thanks for being here, Mike. Representative Francis Gibson is here. Francis, thank you. Representative Mark Roberts. Mark, where are you? Okay, Mark's right there. We also have City Commissioner Larry Ellertson. Larry, thanks for being here. And I know I saw Spanish Fork Mayor Wayne Anderson is here. Thanks, Wayne, for being here. Appreciate it. And I wanted to see if we have any other city officials that wanted to introduce themselves real quick that we missed, that we didn't. I know we've got various from city councils and Steve. Anybody else that we want to have recognized that we might have missed? All right, thank you.
I'm not a city official, but I'm representing the Utah Valley Chamber of Commerce and Valley Hill and Don Hall, but they're up north today.
Okay, great. Tell me your name.
Neil Smith. Sorry, the meeting.
Thanks, Neil.
Baldy, hair's not that attractive.
Thanks, Neil. All right. I did want to mention too that. Oh, and Rick Nielsen. Thanks for giving us the building this morning to meet in, Rick. So Rick is the superintendent of Nebo School District, and appreciate him as well. I did want to excuse Senator Deidre Henderson. She was planning to be here, wanted to be here, and had a family emergency. She actually is at a funeral right now that was unexpected, and so she asked to be excused. So we appreciate her willingness to be involved if she didn't have that family emergency. Real fast, we've got a big group and we want to save our time. We're probably not going to do individual introductions, but I would like to just real quick see geographically where we have representatives from. So if you're here from Santaquin area, raise your hand. Okay, good. How about Payson area? All right. The Salem area? Okay, good. How about Spanish Fork? Okay, thanks for hosting us in your city. Appreciate you being here. Mapleton. Okay, thank you. And how about Springville? All right, good. So anywhere else that we have? All right, Woodland Hills. Oh, I left out Woodland Hills. How about Elk Ridge? I probably should have mentioned Elk Ridge. Anybody from Elk Ridge? Besides, okay, there's a couple of us. Provo? Got a couple, all right. So, all right. Well, we appreciate everybody being here, and we want to go ahead and get started. Just real quick, this is really a chamber-sponsored event, and really the chambers are our voices for business in our communities, and we really want to have our issues focused on the impact to businesses, as we discussed this morning. We've chosen a couple of topics to start off with, and although we don't have to limit the discussion necessarily to these topics both days, but this morning we're going to focus on health care. And then our next meeting, and we'll announce this again, but it'll be on March 9th. And at that meeting we're going to focus on education and public lands. So just know that those are the areas. And we have invited some key experts in those areas to help us frame the issues and the discussion. Really, the goals that we have are to educate chamber members and citizens on the issues, research and understand, and determine the appropriate position on behalf of chamber members. So that's what we want to do. So this morning we're going to get started with the healthcare agenda by asking Scott Barlow, who is the CEO of Central Utah Clinic, to outline some of the key healthcare public policy issues that we want to have addressed during this. So we'll turn the time over to Scott.
Thanks, Kevin, and appreciate the chance to be here, and appreciate the chance to be a sponsor to help facilitate this. I was one of the individuals that helped start the Eggs and Issues 14 years ago in the Provo-Orem area. So we've had this every Saturday morning in Provo-Orem for 14 years now, actually. And Representative Lockhart, you may remember, she was representative then, not speaker, but we had about 20 people that would come, and we'd sit in a little U table. It would be about 10, 12 legislators and 7 or 8 citizens, and great interaction. And that's morphed now to over 200. So congratulations on the interest to have this be the first formal event and this kind of turnout. It speaks well to your involvement and your interest in being a part of the solutions of the needs of the communities that you represent. So thank you. I am from Salem, so this is my area. It's nice to be here instead of trying to drive to Provo-Orem this early in the morning on a snowy day. So thanks to those of you who traveled a little further to come to join us. But I want to just, I put on your tables just kind of a brief outline of 4 key healthcare issues. These are by no means all the healthcare issues that the state legislature is dealing with or needs to deal with. But in any event, these are important public policy issues that they're grappling with that thought we'd use just to try to lay a framework. My hope is to just provide kind of an overall framework of those, and would welcome as the legislators come up and address the issues they're going to address if they could comment on any elements of those that they may have familiarity with. I know some are on some of the committees that are dealing with some of these issues, but some of the key issues is there's an active effort to try to increase funding for the University of Utah Medical School to increase the number of physicians. Given the population demographics we face as a country and as a state, there's a tremendous trajectory shortage of physicians related to population and need. And so the medical school used to have 102 students. They cut back to 82 a few years ago when the budgetary pressures came about. That 102 number has been the same for about, I think, 20 years actually, so it's not even grown even prior to that. And so they're trying to get that back up to the initial number it was, and then up to 20 more. And that's important because if you look at Utah, Utah is a very difficult state as a healthcare provider. I'm the CEO of Central Utah Clinic of recruiting physicians. It has a couple of elements that make it difficult. Utah has a unique demographic basis, and it tends to draw physicians that have some sort of a tie to the values and demographics of Utah. And it's hard for those who don't share some of those values sometimes to feel like it's a state that they want to come to. It has a lower economic reimbursement. When you look at how health insurance reimburses, for example, Utah compared to Idaho per unit of service is a 28% difference in pay to the physicians. And so again, you see some demographic changes that make it, again, somewhat difficult. So bottom line is the University of Utah has been for a number of years now the biggest feeder of physicians for over 30 years in the state, and they're trying to see if they can increase some funding to enable that to increase. You know, the cons of that difficulty, of course, is dollars are precious and they're difficult to come by, and those are tax dollars that I know our representatives really want to be judicious with. So that's a real negative. The payoff for a physician, training for a physician is at least 7 years, and many, if they're specialists, go up to 10, 12 years after their high school, after their undergraduate college degree. And so when you look at that pay pathway, it's quite a lead time in order to try to create that additional supply. So that's just one of the issues I know that is being dealt with. A bill's already gone through, I think even through the Senate, I believe already, at least through the committees. So that's moving forward, so would welcome any feedback on that and let all of us as citizens comment on that. You hear a lot about the term health exchange, and my suspicion is a lot of people don't even know what that means, although it's debated a lot. The Accountable Care Act mandated that exchanges be available for citizens of the country and the states to, basically it's like Travelocity. The idea is to start moving away from employers buying health insurance for individuals to where individuals can go through a portal. Sorry Rick, I just broke your microphone. So where individuals can go through a portal and pick and choose an insurance plan catered to the needs of your family. And so it's kind of a shopping tool that's there. There's currently 2 states in the country that have exchanges. The Massachusetts exchange has been up for about 7 or 8 years. Utah was the second state that started exchange about 4 or 5 years ago. And so again, the idea is just to create a mechanism for consumers now to get more involved in their healthcare choices and their decisions, and creating a tool set that enables you to go and put in criteria pertinent to your family. Do you need obstetric coverage or not? Do you want end-of-life care? Things like that, where you can actually tailor a policy to your individual needs and purchase a policy. The pros of that vehicle is it enables families to aggregate funds. For example, right now in most health insurance situations, if you have 2 people in a household working and their employers each offer health insurance, your choices are to go with one or the other. You can't take the funding of employer A and employer B and put them together to buy a policy. An exchange would enable that to happen, actually, where you can take different employers' contributions and what they're willing to pay for their health insurance to their employees and put them together to one and actually buy a policy with that. You can also use it to match subsidies. So if you qualify for some sort of a subsidy, you can take those dollars, and instead of perhaps being on a public program such as Medicaid, you can take the Medicaid funding dollars and maybe some private dollars, and you can actually again go buy your own policy. So The exchanges become vehicles of that sort of a new economic model of purchasing. Employers like it because it's now what's called a defined contribution plan versus a defined benefit. Right now, employers who offer insurance buy a policy, and whatever the costs of that policy are in terms of what their health care costs are, they have to fund that through their premiums. So if they have a population that has a higher cancer rates or higher preemie babies or whatever other issues may occur, their policy costs go up and they have to fund that via their premiums. The exchange, they can have a fixed funding mechanism. They say, we're going to give you $300 a month or $500 a month. And that way their contributions are plannable, known, and more in their control, which employers seem to respond to. So that's an important piece because, again, states have started it already, 2 states at least, Utah and Massachusetts, but now the federal act requires that to be in every state in the country, and if you don't have a state exchange that meets the federal criteria, the federal government will provide an exchange. And I know that's a big policy debate that they're having right now. I don't even think the governor and the legislature are completely aligned on where they want to go with that, so they're kind of trying to compromise is what I understand, but I'm sure we'll hear more about that. But so again, it has some real pros. The cons of that, of course, is the insurance marketplace has not exactly embraced the exchanges. They feel like it's one more administrative piece that may cost money that doesn't really help people. As that industry has not been excited by some of the mechanisms of that. There's questions about who runs an exchange. Massachusetts is a state-based tool. Utah is a market-based tool where it's run by a private enterprise with, I guess it's not really private, but it's essentially private with some governmental support to it. So again, you've got different philosophical approaches that need to be debated. And then, of course, one of the bigger concerns of exchanges, will it draw people that are real unhealthy to certain populations that make that insurance pooling not very cost effective. So exchanges are a very active effort. It's an important part of the federal ACA Act, and our state has been struggling with how we relate and interrelate with that. And again, the state actually started exchange before that act even was passed. So it's been something that's been working on for a while. Probably the biggest policy difficulty or discussion that you're going to hear about is the Medicaid expansion. The Accountable Care Act provided a mechanism to try to create access for individuals who don't have access to insurance, and they've done that through the Medicaid program. Currently, the Medicaid programs across the country, and particularly in this state, has about what's called a 2-to-1 match, meaning Medicaid in Utah is funded $1 as state funds, and for every dollar they put in, the feds put in $2 to enable Medicaid to be available to citizens. Medicaid has had a very limited criteria of populations, and the federal government has chosen Medicaid as the vehicle to try to expand coverage to those who may not have insurance coverage. You may want to remember the Accountable Care Act mandates, and this was held to be constitutional now through the courts, that everyone has to have insurance as of next year. If an individual does not have insurance, then there's penalties, and they'll start escalating year after year, and they become fairly substantial, frankly. And so there is that need for citizens to figure out coverage issues. Related to that is also the employers are required to participate based on certain levels of employees. So there are some new changes that are coming about that really are going to change the dynamic of those who don't have insurance, so not only be dealing with the fact they don't have insurance, and that makes getting health care difficult. More importantly, they're going to have financial penalties now that are coming about if they don't have that insurance. So there is a need to try to create some different vehicles for those who are in those positions where they may not be able to afford or have access to a health insurance policy through some of their employers. The pro of that is it does have the potential to increase coverage to more populations. The program, from a legislative standpoint, currently the federal government funds 100% of those costs for the first, I think, 3 years, and then they drop down to 90% of those costs versus 66% as their current funding. But that's just the cost. That's not the administrative infrastructure you would need to enroll, track. I mean, there is a state-based cost on top of that has to be considered, but nonetheless, again, from a pro standpoint, it does create coverage for about the 400,000 plus Utahns that don't have insurance. Utah is one of the only states in the nation that's seen the uninsured rate grow. Most states have been working on different reform efforts for a number of years now, and Utah is one of the few states that actually our uninsured ranks are growing, where most states are seeing a slight decline in that population. And so there is a need there to figure out some sort of a vehicle, and this is one that has been made available. The other pro from a community standpoint is when people don't have health insurance, they tend to not get as much health care and delay health care. And when they get it, they tend to take the most common pathways through emergency rooms. We have great hospitals in this community, Mountain View. We have great hospitals in the state. But the reality is people go into the emergency rooms for basic primary care or healthcare needs is not a very cost-effective mechanism to receive care. And the continuity and follow-up becomes very difficult. So there's study after study that shows it's not the most cost-effective way. And we as citizens bear those costs because those costs those are bad debt costs that are loaded into the pricing structures of insurance policies to make up for that. So there is a need to figure out a coverage mechanism of some fashion. And this is one that the federal government has pushed out as a mechanism. The con, where's the money coming from? There's no secret that you just can't print money on copy machines and expect that to work well, and we've seen that in multiple areas with the federal government. So that's a very scary element long term. It's a scary element for the state about reliability of that funding mechanism. They've even articulated it right now being in place still for very long. So there's, the real question is how is that going to be funded? Also, when the feds fund those programs, they create a lot of restrictions. Utah did apply about 2 years ago for what's called a waiver to modify the Medicaid program, and one example of that is they asked the federal government to allow them to start charging, I think, is a copay or a higher copay for people who access the emergency room for minor health issues on Medicaid, and they wanted to raise it, I think, from $2 to $3. Was that the proposal? And that was rejected by the federal government. Again, the goal there was trying to create incentives to get people to go to different places, but yet with the federal restrictions, that wasn't possible. So that's one of the negative situations of using that vehicle, as well as the restrictions and the lack of flexibility to meet the states and the community needs. And then, of course, there's just a real concern in this state particularly, I think, about just the perception of the federal government enabling services of people versus people being more self-reliant. So that's kind of the environment around the Medicaid expansion, but it's a big issue because the state has to do something with that this year as it relates to the Accountable Care Act, and I know there's arm wrestling about that issue, so I'd welcome any input on that from our legislative group that's here. Last item that I just wanted to point out to you is what's called the Clinical Health Information Exchange, or the CHI. Utah leads the nation in physicians and hospitals with electronic health record tools, the ability to capture data electronically and move that data within their systems. And so the CHI was a vehicle that was set up a couple of years ago. It's a privately run enterprise supported by all the groups in the state, including the state government and legislators, to try to create, it's a secured portal to enable providers at the approval of the patient to exchange clinical data sets amongst one another. In healthcare, there's a tremendous amount of redundant healthcare because you go to Dr. A and Dr. B and they don't know what Dr. A or Dr. B did, and so things get repeated. There's a tremendous amount of waste there. And so the idea is to create a vehicle now to enable those systems to work more effectively and communicate more effectively with one another. I'm a great example. I have back issues, and I used to get an MRI fairly regularly to manage that disease, and I got an MRI, which is about a fairly expensive test. This is about 3 years ago, and then I went to California for a football game, and my back went out on the drive there, and I couldn't stand up. So I went to the ER there, and all I needed was an injection, but because it was a narcotic, they wanted to do an MRI. Well, that result was available here in Utah, completely digital for them to see, but they didn't have the access to see it, so they repeated the MRI in the emergency room. So my need for a $100 office visit became a $6,000 medical bill through the ER. MRI. It was 9 hours in the emergency room to finally get the injection I needed for my back spasms to release. And so again, it's an example, and there's lots of those examples in healthcare where just the lack of information movement creates voids of awareness that result in tests having to be repeated that are costly. There's radiation involved in some of those testing, and it's just not in the best interest of our community to do it that way in some respects. It's particularly pertinent to emergency situations where you have an unconscious patient, perhaps in a life or death, where you're having to make decisions of medications, allergies, things like that with an unconscious patient. So again, the ability to access information pertinent to that individual in a very rapid way is of high value to the healthcare delivery system. The concerns of the CHI is the confidence of data security. And we've had 2 unfortunate breaches at the state level with patient data breach. There was one about a year ago that over 300,000 citizens had some of their private health data released to the public in an accident where they had a portal error that enabled someone to be able to hack the database of the state Medicaid program. And so there's a real concern about patient data security given the sensitivities of healthcare information, and that's truly an issue of concern that has to be dealt with from a policy standpoint. There's cost to maintain these hubs and connections. Right now, the CHI has been funded for about 5 years now by physicians paying 1/3 of the cost, hospitals paying 1/3 of the cost, and insurance systems paying 1/3 of the cost, because the healthcare system sees the value of it. So it's been being funded by those individuals. And as a one representing a healthcare group, we operate 88 clinics throughout the state of Utah now. For us, it's a more cost-effective way. We're willing to fund there because we spend loads of resources trying to call and get faxes and get our hands on information pertinent to the patients that we have the privilege to treat. So right now, the private sector of healthcare has been funding it, but the difficulty is Utah, one of the larger health systems in Utah, decided that they weren't comfortable with that just happening automatically without patients choosing to opt into it. Most states who are developing these vehicles have done what's called an opt-out, where you're given a time period to say, I don't want to have my data in that vehicle, and if not, your data is assumed to be in that vehicle. Utah chose to go what's called opt-in, where everyone has to physically sign, I'm willing to have my data be in that vehicle. And if you start looking at the logistics of getting 4 million people, or 3 million, what's the population of Utah? 3 million people to sign a form. How many want to go to the doctor's office and sign one more form? No one does. And to mechanically get the population to do that consenting process has become quite unwieldy. We've been at it for 2 years now, and we have, I think, about 500,000, although 80% of that came from a state law last year that mandated all Medicaid patients have to choose yes or no. They're forced to choose at the time of enrollment, and all public employee health plan patients who are on state insurance of the state government have to also choose. So that infused about 350 to 380,000 people into that vehicle. So bottom line is the CHI's dying because we're not getting the public to say yes to have their data in there, or at least even make a decision yes or no. As a result, the private enterprises are starting to say, you know, we've been funding this for 5 years. At what point do we quit funding it, because it's just not going to come together? So there's been some discussion about mandating anyone on public employees health plan, which would be county, city, governments, school districts, other populations, mandating that they have to make an affirmative choice next year, yes or no, with their data sets. 99% of people that have been presented the choice have made the choice yes. So when the public understands the security mechanisms of it, they've tended to support it, but the mechanics of just doing it has become quite unwieldy, and it's starting to die a very slow death simply because of lack of consent. So again, those are just 4 kind of public policy issues around healthcare that are pretty significant matters. There's pros and cons to both. One of the things I've come to appreciate about this sort of a venue and is the chance to hear from our legislators. It's easy for the press and for us to all see certain issues happen and kind of vilify and think that people are crazy or silly. The reality is when you learn about the issues, they're very complicated, and there's always 2 sides to every story. So it's great to have vehicles like this where we have a chance to hear the broader perspective, so we can offer our input to citizens as to what we'd like to see happen for our community. Any questions for me about healthcare before I sit down? Again, I'm just trying to frame 4 issues that we'd hope they would comment on in addition to whatever else they have to offer. Any questions for me? Again, I neglected to, and I think she just left, I neglected to recognize Brianna, our staff. She's one of our interns. We've got one of our other ones here that's helping us with this meal. I want to thank them for their putting this together for us. They've been great to help us support this, so thanks for that help. So I'll turn this over to you, Kevin.
Thank you, Scott. That's a great job, very succinctly framing these 4 issues, and there are others, but those are the ones that I think those of us in the healthcare industry are kind of the highlights. So I want to turn some time now over to Speaker Lockhart to outline key healthcare matters and actions for the legislature, and to field questions as well. So, Becky?
Good morning. It's good to be here in the southern part of the county. I represent District 64, which geographically is actually simplified. Francis might dispute the line between our district, but it's basically downtown Provo south and downtown Springville north. So I do have a little bit of population of Springville in my district that I'm very happy to represent these next 2 years. I'm going to go off this list real quick, because these are the things that were presented to you this morning. I want to start with the CHI. This is something that as Scott said, we have a bill every session generally that deals with some of the technical issues around the CHI and the opt-in, opt-out issue. We'll probably, as he mentioned, talk a little bit about this opt-in, opt-out, public employees, those kinds of things again this year. But what I think you really want to hear about are the other items. So I'm going to go back to the front of the paper, which is the medical school admissions funding. Sorry, it's early. So, when the medical school went from 102 to 82 a few years ago, I think everyone needs to understand that the legislature did not do that. It was during a time where we had some budget problems. The medical school had, and the University of Utah had some issues with the way that they were reimbursing, and it was a complication. It was fairly complicated, but basically their reimbursements from the federal government decreased by about $10 million, and they had to make some significant internal budget reallocations at the University of Utah and at the medical school. And it was actually the medical school and the university that chose to decrease the class. It was not something, thank you, that the legislature did in terms of we need to cut budgets, we're whacking the medical school. That was a choice that they made internally about their own budgets. So now we are 4 or 5 years in the future, and they're coming back saying we need to increase our class. So as a legislature, it's a little bit frustrating to not have made that decision and then to be faced with them saying you need to fund the increase back to the 102 or even higher to the 122. I only tell you that to give you context of to what was going on there. So the legislature, I think, is very willing to look at this issue. We understand the challenges of the physician shortage with what's going on with the ACA, or as even President Obama calls it now, Obamacare. I think that this issue with a shortage of physicians is only going to get worse. I think that fewer and fewer individuals will choose medicine as a career in the future, and we're going to continue to see that as a problem. So one of our Utah County representatives, Representative Mike Kennedy, who's one of our new freshman legislators, represents Highland Alpine area here in Utah County. He is actually the House sponsor for this piece of legislation, and Senator Valentine, who represents Orem area and Linden, a little bit of Pleasant Grove. He is the Senate sponsor of the piece of legislation that would increase the student count and provide the $10 million in funding. What we have asked for as a House, and even Representative Kennedy has asked that we get some detail. What exactly is this $10 million for? Because we don't, as the legislature, we don't like just writing checks. We want to know where exactly, how much of this is faculty? Is this a classroom? Is this a, are these cadavers? Are the, we want to know exactly where this $10 million will be going. And so we've asked for that information. That will be coming back to us so that we as a legislature can make an informed decision about the medical school there at the university. Let's go to the healthcare exchange. It's probably no secret how I personally feel about the healthcare exchange. We have as was mentioned, we have a healthcare exchange. It has been working for 4 to 5 years. I feel kind of inadequate actually talking about the specifics of this, so if anybody wants specific questions about the exchange, I'm going to hand them over to Representative Francis Gibson, who has served, is a healthcare professional himself and has served on the healthcare reform task force the last few years and is really knowledgeable about the intricacies of the exchange itself. But we've had our exchange. It is a free market, consumer-driven vehicle. It is for small businesses. It's still very small. It's kind of, I guess you could say we're out of beta testing, but it's still very small, and we're still trying to figure out how to make this thing work. It does allow individuals who work for different companies to come into the exchange, pool their resources, and buy an insurance product that meets their needs instead of whatever their employer wanted to provide to everybody no matter what. So that's a positive thing. It's consumer driven, as I said. We're moving along with that. There are some hiccups. Every year we have to come back generally and make some adjustments. The insurance carriers have concerns, about the risk pools, those kinds of things. Insurance is a complicated issue, and so we've been kind of moving along slowly, trying to see if this is going to work. Now, this is very different from the Massachusetts exchange. Massachusetts has an individual mandate, if you remember, and almost everyone goes onto their exchange. It's highly subsidized. It's very large because it has all of the people in the state in it. Utah's is very different. So here's the deal with the federal exchange. Under Obamacare, the states are you have the individual mandate, which the state of Utah joined her sister states in suing over the constitutionality over the individual mandate. We know that the Supreme Court decided that the mandate is constitutional. We were not real happy about that as a state, but that is what it is. So now the federal government is saying that you have to have exchanges for individuals to go in and purchase their insurance. But the states don't have to do it. The federal government, if the states don't choose to create these exchanges, the federal government will come in and do it. I think the federal government should do it. I don't want anything to do with Obamacare. I didn't vote for it. My constituents, as the majority of my constituents, didn't want it. Not one member of our federal delegation, including Congressman Matheson, who's a Democrat, not one of them voted for Obamacare. We sued over the constitutionality of Obamacare. This is not a piece of legislation that the people of Utah agree with, but it is the law. It is the federal law of the land. So let's let the federal government do it. Why would we want to be involved in it? If they're going to do it, let them do it. So my position has been, fine, come and do it. And when they have problems and challenges, they can deal with them. I don't want state employees to be hearing all of the complaints and hearing about all the challenges, and the state legislature to be responsible for what I believe will be serious, serious problems in this system that they've set up. So that's my opinion on the exchange. The governor and I think the governor wanted more information, and that's what he did. He got more information. He went back and talked to Secretary Sebelius, drew some very hard lines in the sand and said the state of Utah will not enforce the individual mandate. The state of Utah will not do certain things. The secretary took that information, and we'll probably know in the next couple of weeks how the federal government, how HHS feels about the position of Utah. Let me move into Medicaid expansion, which is the other part of the Affordable Care Act. This is a difficult issue because we know that there are individuals who need help. We know that there is a group of people who I'll just say it again, who need help. And the federal government, this is one of the good things about the Supreme Court decision on the Affordable Care Act, is that the states cannot be coerced or compelled to change and expand Medicaid. So this is also a choice of the states, whether or not we expand Medicaid. Well, the federal government has done in the Affordable Care Act what they always do, and that is to tempt the states. They tempt us with what I would call crack, federal crack. It's called money, but federal crack. And they get it, they hand it out, and they say, look, we'll fund it 100% for 3 years. And then we'll fund it at 90% forever. It's only going to cost you 10% to cover all these people forever. And we go, oh man, we have people who are in need. We know these people may, need help. It's free money. It's only 10% after the first 3 years. That's not that much. And the states say, okay, we'll take it. And then you get hooked. And there's no way off. There's no way off. You will never cancel a program, especially a program like Medicaid, where you're helping people. You just won't do it. okay? So the federal government does this time and again with this temptation of free money. Ladies and gentlemen, the federal government is in debt $16 trillion and growing. We are printing money, not the state of Utah, but the federal government. When you print money like they're printing, it never ends well. Never. Read your history. Okay? One legislature cannot bind a future legislature. We know that here in Utah. One Congress cannot bind a future Congress. The Affordable Care Act says we'll pay for it for 100% for 3 years, and then it'll be 90% forever. The next Congress can change their minds and change that on us, but we're already in. We've already provided services to people. We're $16 trillion in debt. They're going to have to do something at some point, okay? So what we fear is that 3 or 4 years down the road when we've said, yes, we'll do this, is free money that's coming to the states. They'll come back and say, we gotta make cuts. We gotta make cuts. And there's, what's the easiest thing for Congress to do when they wanna make cuts? Cut the money to the states. So they'll come back and say, well, you know what, we told you it was 90%, but that was a Congress back in 2010. We're a Congress in 2000 whatever, and we decide that we can't afford that anymore. So it'll be 80% next year, and then it'll be 70% the year after that, and then it'll be 60 and 50 and 40, and who knows where it will end. And the states will be left saying, what happened to us? We're hooked on the crack, and we can't get off, and they're decreasing the revenue. This is our greatest worry. It happens over and over again. So, although we understand the need to serve people, to have these individuals who really do need help, this is our greatest fear. We've seen it happen before. I believe that the state of Utah makes good decisions. If the federal government would just give us this money that they're already taking from our people in your taxes, just block grant it back. Without all the strings, without all the rules. Just block grant it back, and I believe that we will be able to cover more people, cover these populations that they're wanting us to do in the expansion, cover many of these people with better benefits if we're allowed to do it the way we do it here in Utah, without all of the federal requirements. So that's the discussion that we're having around Medicaid expansion and around the exchange. What we hope will happen with the exchange is that the federal government will come in and do the individual exchange and implement the individual mandate, the tax subsidies, all those, based on your income up to 400% of poverty, you can get a subsidy to purchase insurance on the exchange under the ACA. So we hope that they will kind of do that and leave us alone on our small business exchange. And we will continue to run Avenue H, which is what it's called, on our own, with our own regulation, free market, consumer-based, and see what happens. We'd like to continue along with that one, have the federal government do all the implementation of the Affordable Care Act, and kind of run them parallel and see what happens. I think that's probably the best outcome on the exchange issue. The Medicaid issue, we're still discussing, and one of the nice things about the Medicaid expansion is there's no hard and fast deadline on that one. So we can decide as a state to do Medicaid expansion today, or tomorrow, or next year, or not. And it depends on when we decide to make that decision. So we're involved very heavily right now in our appropriations subcommittees, hearing about all of the issues. You probably want to hear a little bit about the budget in general. We will have the budget numbers, hopefully, by the end of February, so that we can begin to put together the budget for the next year. We adjourn on at midnight, on March 14th. Congress probably won't have made any significant decisions by then. Everything that Congress does in terms of tax policy, in terms of the debt ceiling, sequestration, all of those decisions that Congress has yet to make will affect the state budget. It will affect our state revenues. So we're very concerned about setting expectations in the state budget that may or may not pan out over the summer or into the fall. So you will see us be very conservative in terms of how we budget. The kinds of revenues that we are making assumptions will be there in the future There's just too much uncertainty out there, and so we're going to be very careful, and hopefully we won't have to come back later in the fall and make reductions. That's really not a fun thing to do as a legislature, is to find out that you had less money than you thought you had and to have to come back and make reductions. What we'd really like, we'd really like to know exactly the revenue and set the budget based on the revenue and come back next year in a regular session. I guess what's better, just a little bit less fun than that, is to set the budget and then be told later on in the year we have more revenue and come back and decide what to do with that. That's always more fun than coming back and cutting. So that's kind of where we are with the state budget in general. I've got two of my newest colleagues here, Representative Robertson, Representative McKell, who are, we have a fantastic freshman class in the House of Representatives. It's a very large class. It's 19 freshmen. They are dynamic individuals who know the issues, who know their principles, who believe in their principles, and who vote that way. And it's very exciting to see them engage in the process. And these are two of our freshman members in the House. Utah County, 8 of the 14 of us in the House from Utah County are freshmen. It's a very large new class here in Utah County. We're very excited to have these new colleagues. So, and Representative Gibson is, like I said, an expert in healthcare. He's also the chair of the Education Standing Committee in the House, and so knows education policy very well. And I think you're going to have him talk specifically about that in a couple of weeks. Is that right? Great. So he'll know by then and what's going on in terms of the policies that are coming forward out of the legislature in the education area. But I think you wanted to have some questions. Is that right? For me or any of, I'm going to allow some of these guys to answer questions too. Okay. Anybody? Yeah, Dr. Francis.
If we don't take Medicaid expansion, tell me what happens to the group of people that are uninsured now but don't qualify for Medicaid but can't afford the uninsured pool that the state has.
Yeah, are you talking specifically about that one kind of whole area?
Yeah, they were supposed to go up to 130%
Yeah.
of the federal.
Yeah. We're aware of that. I know our committees are starting to talk about that. That might be something that we as a state are willing to address. Another thing about the ACA is that it gives the states the ability to say, well, we're not going to go all the way here, but we might go to here, or we might choose a certain population. We have a choice in how we expand Medicaid in a lot of ways. We don't have to take all or nothing. So we do know that there are, I believe it's adults without children. There's a population there that has, that doesn't make enough to qualify for the subsidies in the exchange, but doesn't have coverage under the state Medicaid plan right now. So that's something that we're aware of, that we're thinking seriously about.